IDF. Professor Akhtar is a diabetologist, a professor working in Norway, and he's the upcoming president of IDF in a year's time or so. Professor Akhtar, the floor is yours.
Thank you, sir. Thank you so much, and my apologies for this, for the lack of my knowledge, in the modern technology. So I had to get some help from my son finally. So I'm back to business, and but I know that this discussion with Andrew was probably more interesting than my talk because this is something you already know. But I would like to give some perspectives in it. The next question is the key facts. As we have saw that the number with diabetes rose from 108 in 1982 to 422 million in 2014, and it is increasing. And we see that it is increasing from every year that we are going. There is a 5% increase. The diabetes prevalence has been rising rapidly in low and middle income countries. And this is quite important to recognize that in the donors community, even in the Western world, I'm sure that Andrew Bolton is aware, I'm fighting with the Norwegian Research Council continuously because they do not see that NCDs, non-communicable disease and diabetes is a threat to the low and middle income countries. They still think infection is the main cause and undernutrition is the biggest problem. So giving this diabetes is a major cause of blindness, kidney failure, heart attacks, strokes that we all know. And in 2016, an estimated of 1.6 million deaths were directly caused by diabetes. And this is something that we need to assert the kind of death, because the politicians generally understand the death they have because they want some hard facts in terms of the death. Almost half of these deaths attributable to high blood glucose occur before the age of 70 years. That is, we are talking about the premature deaths, not before the age of 70. And the WHO estimates that diabetes was the 7th leading cause of death in 2016. And this is sometimes we forget to use in our discussions. And as you said, that as Andrew was saying, that even, for example, if we could have a kind of statistics which economical statistics where you can show that only by simple preventive measures, screening and preventive measures, we could save a lot of money, and that probably politicians would also understand. And this is something that, unfortunately, the thing is this: in our part of the world, I'm from Bangladesh, from Asia, and I understand the situation in the Middle East very well. Most of the doctors, they don't think that prevention is our part. They say that this is only treatment, the medication. The very moment the medication is not there, this is not the doctor's job. And this is a very big misunderstanding, because doctors must engage in the prevention of diabetes. And then we said that we know that diabetes, we said that diabetes is an explosion, and we are putting this all the risk or all the reasons for the increased diabetes on obesity, which is definitely a major cause. But we have to understand that in many parts of the world, for example, when I'm talking about the Indian part of the world, more than 50% of the people with diabetes are not obese. And this non-obese related diabetes, we have very little focus on, given the huge population in India, Pakistan, Bangladesh, and these parts. Even a fraction, as I said, 50% is a number. If you see in terms of the total numbers, is a huge number. So we must take the obesity seriously, but at the same time, we must also expand our thinking that people who are not obese, they can also have diabetes. You see that we have always changed our prediction from, for example, 366 million to 530 million, and there are many reasons that why this prediction doesn't fit. And because the risk factors that we think, it changes continuously. The preventive measures that are put in place, that changes continuously, and therefore the estimates that we make in 2016 changes in 2018. And this assumption is going to have a major effect because of the COVID-19. We know that in this pandemic time, the obesity level will increase because we have restricted movements, and we have lower glucose control because people are not going to the doctors. So there will be, as Andrew has already said, limited food availability and accessibility. We know that healthy diet is getting difficult in many areas because of and then they're using more junk foods. Increased stress. This COVID has caused a lot of stress, and also the treatment itself, the side effects that I'm not getting into it because we had lots of discussions in terms of for example, SLG2 and for example, number of drugs that we are using. And the good news is this: until now, there is not a signal, but there is not scientific evidence to prove that these drugs has any adverse effect. The last and most important thing that comes from the studies from the UK, that the SARS-CoV tropism of beta cells should lead to cell damage and an impairment in insulin secretion, triggering hyperglycemia and ketoacidosis. This means that this virus itself can cause diabetes. The virus, it has also shown that this study has also shown that it also can increase not only type 2, but also type 1, because by creating an autoimmune destruction. So this virus is the prediction that we are saying that this about 500 million people, that is going to change dramatically because of this COVID. And this message we should bring to the politicians, to the news. You know that I'm particularly looking at you in the Middle East. For example, if you look at, you already have an approximate rise of about 96%. And that Middle East is one of the most affected area in terms of the prevalence of diabetes. We know that it's about 4.9 million deaths per year, and 50% of the deaths are under the age of 60 years of age. That is the premature death I talked to. That intersects with all dimensions of development, and therefore the diabetes is not should be seen as a disease, but is as a developmental issue, because it is halting the development in the particularly in the developing and developed country, in the developing and the poor income countries. And it says that about 11% of the whole worldwide health expenditure is related to diabetes, and it costs about $612 billion. So it's a huge area of concern, and there is potentialities for all diabetes associations globally to focus on these issues, and so that they can create their advocacy for the cause. If you look at, for example, if you saw in terms of number of people, then it's not, for example, the Middle East is actually, we do not see it. But if you look at the prevalence of diabetes, you see that, for example, in terms of highest prevalence of diabetes, you see Kuwait, Lebanon, Qatar, Saudi Arabia, Bahrain, so United Arab Emirates. And you can see that this is going to be worse. So if you think in terms of not the number of people, because in the Middle East, there is not enough number of people, but if you see in terms of prevalence, this is one of the major hotspot for diabetes, and their focus must be done here. And you see that diabetes is the leading cause of death for worldwide, 30% loss of life expectancy from diagnosis to diabetes. Currently, there are about 425 million people living with diabetes, and the biggest group is 40 to 60 years. And by 2045, the number of people with diabetes is expected to rise by 48%. As I said, that these 48% could be dramatically different when we are coming to this end because of the pandemic situation that we are saying. In terms of complications, we say that diabetes is among the leading causes of kidney failure, more than 50%, cardiovascular disease, about 70%. Diabetes is the main cause of partial vision loss of in people over 20%. Diabetes stimulates various psychosocial conditions, job, family, driving, mood disorder, quality of life. So you see that is, as Andrew was saying, that this is a kind of cancer, that we should be thinking that it is cancer. It's a societal cancer. Diabetes is not an individual cancer. Diabetes is a societal cancer. And you see that where it happens. So you see that it's there's 4 out of every 5 actually undiagnosed cases of diabetes remain in the in the poor and developing countries. So therefore, you see that we need to say, and therefore the explosion of diabetes is going to happen in the poor and low and middle income countries. And this is important for us to understand that this is coming. And 80% of diabetes cases occur in low and middle income countries. And 35% of the cases are undiagnosed. It differs from country to country, and 50% in low and middle income countries. So you see that it's an unexploded bomb that we are actually heading. And it's unfortunately that we are not paying enough attention to see that how dangerous this is. And for example, in 2020 and 2030, if you look at this, for example, the demography, you see that look at this, for example, in the age in this time from 20. So in the developed countries, you see that here this at the age of 20 to 44, that where it is. But in the developing countries, you see that it is already up to 40 and into 2030. So it will be more than 50% already in this age group. In the 45, so you see that the reason that I'm showing this picture is showing that the people in the productive years of life, this will be hardly hit in the developing countries. And therefore, we must take it seriously, as I said, that this is not a disease, we should not consider it as a developmental issue. And that the number of deaths attributable to the diabetes is about 2.9 million, or 5%, 5.2% of total mortality was related to diabetes. And so this and for example this was in 2005, and if you look at this, for example, the preference to HIV deaths, the worldwide it was about 3 million deaths. So you see that we are in the same position, but if you look at this global preferences from the WHO to the international community, it's about 35% of the donation goes to HIV/AIDS, and it's about 2% of this. I will show you the statistics later. That is going for non-communicable disease, not diabetes, non-communicable disease in general. And this hazard ratios, this is impact of glucose tolerance in diabetes, and you see this that the relative risk of death. You see that in normal glucose, impaired glucose, and for example with diabetes, you see that there's a huge risk. And we all know that this COVID-19 is actually increasing the death in the people of diabetes. So I think this disparity will also increase. So COVID has impact on every aspect of diabetes for the increased prevalence and complications, and also in terms of the death statistics. So if you look at the age standardized deaths, it is also said that, for example, in terms of the non-diabetics and non-diabetics people, so it's a huge difference between this, for example, in terms of in the risk for death. So giving these things, I think you all are aware of this. I'm not saying anything new, but it's just to focus that how we should come up with our advocacy. And then what the IDF's role in the International Diabetes Federation is, because I often encounter the people that what IDF is doing, what we do not see. Why should we need the IDF in the International Diabetes Federation? That International Diabetes Federation is the global advocate for more than 465 million people with diabetes worldwide, as well as families. If you say global, in the global platform, this is the only organization that can bring the voice of the people of diabetes on the global fora, on the UN or WHO. And the IDF has 7 regional offices. The principal aim of the regional offices is to bring local needs and activities to the attention of the local diabetes community, to translate global activities, objectives to the regional context, to support the work of the IDF. So these are the things that we are working, and I know that we have the chairman of the MENA region is present, and the chair-elect of the MENA region is Dr. Sandeep is also here. So this is that we have 7 regions, and this is one of the things that we, both Andrew and I, agree that we must strengthen the regions. Without strengthening the regional offices, IDF office in Brussels will be ineffective. So with more than 230 members of more than 170, IDF is a legitimate voice of the global diabetes community, and this is sometimes we misunderstand. You can go to any other organization, AASD, ADA, which attracts a lot more people than IDF. I have nothing against them, but they are not representing you. This is the only IDF that represents you. IDF enjoys the official recognition of the WHO as well with UN, economics, and social committees. So this is the picture of the 7 regions that we have, and that's these 7 regions. So what is the mission of the IDF? To be the leading authoritative global voice for the people with diabetes and those at risk of diabetes, and improve the quality of life for the people with diabetes, prevent type 2 diabetes, and fight discrimination against all affected by diabetes. And sometimes we forget, and I'm putting this mission because sometimes we think that this is not the part that where the doctor should engage, but this is the mission of the IDF, and we must engage in prevention. We must engage in fighting against discrimination, and improve the quality of life for the people of diabetes. So this is important, and I'm not saying that doctor alone would do, but doctor should be part of the team that is involved in this mission to promote diabetes care, prevention, and cure worldwide. So we have three different ways, and these are the partnership that is a sustainable and strong organization, global at regional level. And we have a policy of high quality research, policy development, and this quality of research, which we hope that, as you have probably noticed, that during this COVID time, we have come up with a special issue on COVID-19 and diabetes to bring the focus on from the scientific side on the risk of diabetes due to the COVID. And this is something that we would like to, we hopefully that we will try to promote and in our future work, but we need cooperation from the regions. But because we want to have IDF, my view is that IDF should present the data from our regions, not the super research that was done in the US. Presents the globally recognized authority for diabetes, and it's a globally that IDF has been recognized. But for this, we need sound administration, good governance, and financial stability. As you have heard, maybe some of you know that our situation on financial stability is now not that solid as it was because of some kind of misconduct, sorry to say, or some kind of mismanagement in the past. But we are trying to get back, and I think now the good news is that we are coming back. We are gaining the trust of our partners, and the board is working unitedly, and hopefully that will get over the dilemmas that we have. So IDF engagement is education. As you probably all know, that we have an IDF school of diabetes, and this is important for us to know that the IDF have a kind of we have three platforms. One is the global. The second thing is a regionalized, and the third one is the complementary. So that's how we are working, and this is actually increasing. And we hope that we, in partnership with the region, that IDF school can really engage in promoting diabetes education and diabetes training in all regions, all in our 7 regions. And we also are we also trying to get into prevention, access of care, epidemiology of public health. You also know that the global atlas. Sorry, that in the epidemiology and public health, as you said, that there is a global atlas, burden of diabetes, that we are putting. So in this, we are trying to say about the cost effectiveness of the diabetes. So if for your advocacy, this information is available in this sites. So we also have different campaigns, and which is supported by the World Diabetes Foundation. And then we say that WHO and the IDF, if you say complementary strengths of WHO and the IDF for awareness raising, is that WHO works with the governments and strong public health voice. WHO office is almost in every country. Global References Center for Health Statistics has prestige among governments and health ministers. What IDF has? It works through member associations. We work through the member associations, not the governments. We have a strong lay and professional advocacy voice. We promote those people, and in the professional and lay work. We have a network of member associations that is, as I said, that from 170 countries. So we have a network of member associations. It's a well-developed secretariat to respond to calls for information. Of course, with cooperation with WHO, but we are saying that these are the strengths, and therefore we should be collaborating, because the strengths IDF has, WHO don't. WHO has the strengths which I do not have, IDF do not have. And therefore the collaboration between WHO and the IDF is very important, and has a prestige among NGOs and private sectors. So you know that UN resolution of 61/2025, it was an achievement advocated by the IDF. At that time, it was, I don't remember the name. He was Australian, the president. Andrew, could you help me with the name?
Martin Selig.
Yeah, Martin Selig. Actually, I'm very proud also to add that actually Bangladesh raised this issue on the UN, because many countries, the rich countries, they didn't want to do it. So Bangladesh did it, and we got this UN resolution. We also have a Gulf Cooperation Proclamation. So this is something that we can use, and we can go to the government, and this is signed by Bahrain, Saudi Arabia, Kuwait, Oman, Qatar, United Arab Emirates, and Yemen. And this is the joint statement of the Ministers of Health for the Cooperation Council stress on diabetes. It's signed by all. We have documentation. We can go for this advocacy to this government. So, and this, our regional office can effectively use this document. And the last is the funding of non-communicable and chronic diseases. You see that global NCD diabetes and others. If you see this one, that this is the NCD part, that NCD is diabetes and cardiovascular disease, and this gives you WHO expenditure on NCDs is only 3.5% of the total budget. And this brings to 2.9 million official overseas aid to the health sector in 2002. It's an old data, but it hasn't changed. Only NCDs got only about 0.1% of 2.8 billion. So you see that this is something that we need to fight. We need to focus, and it is of course IDF will fight, but we also need the support from the regions and the member associations. And for this, we said that provide evidence that diabetes is increasing during this pandemic. People with diabetes are at 3 times higher risk for complications and death due to COVID-19. And policies to combat COVID-19 must include NCDs and diabetes in particular. So this should be our focus, that we should say that we cannot fight COVID-19 without addressing the issue of diabetes. And this must come forward. So in summary, what we can say is that based on the demographic changes alone, the numbers of persons with diabetes in the worldwide will more than double in the next 30 years. And in developed countries, they will increase by 30 to 70%, mostly in the older population. In developing countries, it will increase by 250%, and mostly between 45 to 64 years of age. So it's effectively the developing countries far worse than the developed countries. These projections do not take into account any increase that is attributable to future concerns like obesity, and now that we see that in COVID-19. So about 3.2 million excess deaths were attributable to diabetes in the year of 2000. In the US, this was 9% of all deaths. The number of deaths attributable to diabetes in future years will increase, especially in developing countries, because we see the complications. When you have this diabetes, duration of diabetes is related to the complication of diabetes and death. And since you are getting it at an earlier age, the complication and death will increase. So in conclusion, what you can say that there is an increase in type 2 diabetes and obesity represents the major public health challenge for the 21st century. The estimate of the future burden currently used to seriously underestimate what is going to happen. And with this, I will say thank you for your attention. Thanks.